Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. And if you've been here before, you'll know my name is Leslie Rattan, and I'm really pleased to be moderating our ongoing webinar series, which was developed for people that have suffered concussions, for those that are close to them, their family, friends, and also we have a number of healthcare providers that are also attending the series. They are recurring every other week on Tuesday evening at 6 p.m. and you'll know that they're free. They're also recorded and then put up on the Canadian Concussion Center's website. So if you miss anything or you want to rewatch something, you can find it there. And Christian has just put the post into the chat so you can see it. So you'll also know that each session generally focuses on a different type of symptom of concussion. And we have an expert speaker who is with us generally for, with us for the whole hour, but it presents for about half the session, and then we open it up to questions and answers. So when you look at your Zoom screen, you'll see that there's a Q&A at the bottom, and that's where we would ask that you put in any questions that you have for the speaker. And if you're having any technical difficulties, please put those into the chat, and Christian will help you out. So what we've also been doing, we're just going to run a short poll because it's really helpful for us to continually get a sense of who's actually in the audience. So I'm just going to wait for Christian to put that up and give you a second to fill that out. Thank you very much. And so this evening, I'm really pleased to introduce Dr. Paul Ranalli, who is back with us and is going to be presenting What Vision Therapy and What Vision Therapist. Dr. Ranalli is a Toronto neurologist, neuro-ophthalmologist, and neuro-otologist. He did all of his training at the University of Toronto Medical School. He indicated when dinosaurs roamed the earth. Neurology residency, neuro-ophthalmology fellowship with the late Dr. James Sharp, and also eye movement research at the Playfair Institute at the Toronto Western Hospital. He's a consultant at the Humber River Hospital and Toronto General Hospital at UHN. He also performs neuro-ophthalmology evaluations for the Ontario Workers' Safety and Insurance Board through the Toronto Rehabilitation Institute. He's an expert evaluator for the College of Physicians and Surgeons of Ontario and the Canadian Medical Protective Association. He's also a member of the North American Neuro-Ophthalmology Society and currently appointed to a select working group developing guidelines for vision therapy. His opinion is widely sought in insurance and medical legal cases across Canada. So welcome back, Dr. Ranalli, and I will turn it over to you.
Thanks, Leslie. Just going to get the screen up. So welcome, everybody, and thanks for coming. I have quite a few slides. I may skip over some, so I hope not to make you more dizzy or photophobic than you may be already. But I'm going to look at it from a point of view of a specialist. When we look at people after a knock on the head who have visual problems, first thing a doctor has to do is think widely. What were the visual issues in the person before the accident? I'm going to talk briefly about rare and severe tragic visual injuries that hopefully none of you have and won't be the focus of vision therapy, but just to let you know the spectrum out there. Then we'll talk about mild concussion, MTBI, managing MTBI visual issues. And then we'll, of course, be addressing the neurooptometry techniques. And really, it'll be a critical review, and not to be too critical, but or to make recommendations for or against it if it's your own choice. But I think you should know what evidence there is or is not underlying it, so you can be an informed consumer. And then we'll finish off with the way forward, some of the newer things. So as I mentioned, everybody is coming from somewhere. So when a patient presents at a doctor's office after an injury, let's say a head injury, they have a lot of problems, and there's a natural tendency to be reductionist and think most or all of them came from the injury. But in terms of vision, people have issues before, and they have to be recognized. So the most common one is, do they need glasses? And if so, have they been prescribed, and are they up to date? So refractive error is the term for needing glasses. myopia, nearsightedness, hyperopia, the opposite, and astigmatism, irregularities on the lens. So people may or may not have had their visual issues addressed or kept up to date. So that will make vision worse than it should be otherwise. Then there's other rare things like strabismus, which is misaligned eyes from birth. And often one of the eyes has low vision, a lazy eye. There can be nystagmus, which is a rhythmic movement of the eyes that's a pathologic sign if it comes on new in an adult. But there are people who are born with it, and there are certain patterns, and I have to recognize that. And then there's rare syndromes. So glasses, pretty boring topic, but it's important for us. So most people who are myopic, they actually, paradoxically, they focus too strongly in front of the retina, and we need to have a concave lens that will weaken that and put it back in the retina so you can see. Now, of course, at certain ages, especially getting into the 40s and 50s, we get presbyopia, age-related changes in the lens of the eye, which makes you unable to see small print. You have to hold it further away. Now, the age range for that is you just don't see that in younger folks up to the high 30s. And the ages of 40s and early 50s is when it really becomes prevalent. And people come in at this stage, they may or may not be aware of a reading need or had it addressed, or they just put up with it, or they'll say, "Doc, I just threw on a pair of cheaters," which is a dead giveaway that they have had some reading refractive issues. That has to be recognized. It may be worse after the concussion, but you have to figure out what part was before and what after. So that's the glasses issue, strabismus. So this lady is looking at us with her good right eye, but the left eye, look, it's way off, wandering off there. So it looks, I'll be a very cockeyed sort of look. It's a very obvious case here. Now, if she gets knocked in the head and goes to emergency, they might get quite fearful. They might think she has a partial third nerve palsy or something. But in fact, she's had that all her life, and you have to ask her that. Sometimes the eye that's deviated outward has low vision as well. So one of the things we have to factor in, because she could also have concussion-related visual issues, but you have to see it on this background of the way she was before. And there's a rare condition called Duane syndrome, which is another version of it. So now the tragically bad issues some people have. Here's a CAT scan of somebody who's had a catastrophic head injury, and here's a layer of blood on the left side of the brain, pushing the brain over and pushing the ventricles over. If this person survives this injury, they'll probably have a loss of half of their visual field on the other side. Or the optic nerve itself can get crunched or stretched by the concussive trauma of the event, and the axons get damaged and they blank out. Here's what looking in the back of the eye looks like in someone who's actually had the optic nerve like fatally damaged, with all kinds of blood and swelling all around the optic nerve. And that's a terrible looking picture. And after 6 to 8 weeks, the axons in the optic nerve die off, leaving a very pale, this is a more orderly looking picture, but that disc should be pinkish if it had good visual neurons in it. And when they die out, it looks very pale. And that's an eye that's lost most or all of its vision. There's no coming back from that. But if it's just one eye and the other eye has decent vision, you can get by quite well. There's lots of people driving outside around the province with only one-eyed vision. They can drive with a general license, not a commercial license, of course. So that's irremediable, but not necessarily a huge knockout to their ability to get around. They lose three-dimensional vision, so they can't judge distances very well. They have to be careful. So that was number 2, afferent vision. Now the central visual pathways, let's say vision gets in through the optic nerves and is going through the brain. This hemorrhage on the left side of the brain is probably going to knock out the pathways of vision going back the other way. Here's another combination of hemorrhages on the one side involving the occipital and parietal lobe. That's where vision from the eyes ends up, on one side and the other. So this person has so much damage here, they will probably have lost the visual field on the opposite side. And here's a depiction of what it would look like with a hemianopic patient if he was visiting Paris and standing on the top of Montmartre and seeing the Eiffel Tower and about half the city in each eye. When you put those two together, you're still only going to see half vision. It could be clear, and you can look around and with a reduced field of vision see around, but you're not going to see anything on this side, which makes it a very dangerous defect. And people obviously can't drive after this, and even stepping off the curb can be dangerous. They have to learn a lot of techniques to be careful. This is a picture of the bottom of the brainstem with blood vessels coming off. And the reason for showing that is when there's brain swelling from a bad injury, the brain swells and pushes down to the top of the brainstem. And these two vessels coming off here, the posterior cerebral arteries, they send blood to the back of the brain where vision is recorded, the occipital lobes. So often they get pinched by the swelling and blocked off, and you have a stroke, infarction of the occipital lobes. And this unfortunate person has lost function in both occipital lobes, one side worse than the other, and they will have almost no visual field, so-called cortical blindness. And this is depicted on the MRI scan with diffusion weighted imaging. So when we do the formal visual field, those of you who, let's have glaucoma or go for regular checkups, you may see a printout of the grayscale of your vision, which the light gray, lightish here is normal. Here's the normal blind spot in the left eye. You don't see it on the right eye because the entire right side, sliced right down the middle, is gone in this person. And this is the right side gone. We call it a right homonymous hemianopia. Homonymous means it's the same more or less in both eyes. And that's one of the major defects. So what we can do, and has been done, is to try and train people to look into the blind field and give themselves a little more safety. So here's about a 5-day-old infarct of the occipital lobe in this person. So again, this is where vision is on the back of the right side of the brain, and on the left side, you see it's quite normal here. So they would have lost vision on the other side. Things are crossed in the brain. But the areas in front of it are neurons that take the visual signal not to see, but to direct the eyes towards a stimulus. So we can use those leftover neurons to try and allow them to search. So this has been done for quite a while. There's been 17 trials on retraining people with eye movements to search their blind hemifield. And it's a difficult thing. They do 4,800 trials over 14 hours of practice over 5 weeks. But most of the studies were positive at gaining a little more visual field, not miracles, but pretty positive. And this one study looked really good. They claimed that they were able to shift over the blind hemifield by 5 degrees, which doesn't sound like much because the whole field is 90 degrees, 90. But that was something. However, they used the same equipment as the training equipment. And when other examiners got them into a proper independent perimeter, they noticed that it was 10 times less improvement, less than half a degree. So it wasn't quite as exciting. And then there were further disappointments. They couldn't repeat the study, another author about 7 years later. And then later still another trial found a 1.7 degree improvement. So it was something, but it's pretty limited. They wondered whether they were actually stimulating this thing called blind sight. Blind sight is where you can't really see, but you're kind of aware of something in that blind field. It gives you some sort of warning. And they might have been training that, and they did trials on training blind sight, and they were able to improve things a little bit. But when they asked them about activities of daily life, they couldn't see that there was actually any real improvement. It was only 1.6 degrees. Now, these studies weren't particularly well done. There's no control group. It was just open label and no control method. And this is the way in science, you actually see whether something really works. You have to do like a fake therapy and compare it to the real one. And that's going to be a theme when we get into the optometric vision therapy. So, however, these trials, if you want to try and teach someone to search for their blind hemifield, they are available online. And as I say, the results aren't terrific, but there's something. Now, since 1920s, people have tried to rig up prisms or mirror things to try and gain back some awareness of that blind field. But the problem is with early lenses, they were in both eyes, and it caused double vision, and the patient had to look that way to take advantage of it. And it was very confusing. Then they started using it just in one eye. And this study was a well-done one, crossover design. The person was their own control. They looked into the blind field, and they compared that looking into the good field. But they still were a bit disoriented, and it was left to them if they wanted to drop out, they could. But at 6 months, about 41% were still choosing to wear the lenses. And they got some benefit, at least in terms of safety. But they're clearly not for everyone. And of course, the big question is, doctor, can I drive again? And this is one of those defects when you really can't, no matter how hard you try, because you literally wouldn't see like a cruise missile crossing until it went past your nose. That's such a total blindness, even with both eyes open. They tried a small pilot study, and there was some indication they could detect some hazards when they did real world driving scenarios in a simulator, but no one has gone on record as saying it's safe enough to drive. So You got to be chauffeured around with that defect. Now, double vision can occur because some of the nerves that go to move the eye muscles come through the base of the brain, and they can get stretched or knocked out, fourth, sixth nerve, or you can bash the eye in front, the orbit, causing hemorrhage and fractures of the orbital rim. That can disrupt the muscles in the eye. Here's a patient who is trying to look up. So the good right eye is looking up, but the left eye can't. Not because it's paralyzed, but the muscle down here is actually trapped. And here's a CAT scan through the orbits. Here's the normal size. You see a nice thin rim of bone around the orbit. And these are all the muscles here. Everything's fine. The black is the sinus. That's air inside your maxillary sinus. But here, look at this big droopy thing. There's been a fracture of the base of the orbit, so-called blowout fracture. And tissue, including the muscle below the eye, is getting down trapped. So that person can't look up because the eye is sort of tethered. But fortunately, we have excellent orbital surgery and plastic surgery colleagues who can push that back up, repair the floor with some fascia, and get the person back looking again in all directions. So mercifully, those major injuries are not going to be our focus anymore tonight. But getting into milder concussions, there's some terminology here now. Neurosurgeons and neurologists often use the term closed head injury, but it's the same as concussion, and there's different grades. Now, we use in neurology the American Academy of Neurology scale developed by Kelly and Rosenberg. There's 3 grades, 1, 2, 3. So 3 is the worst. If you're knocked out, you're grade 3 automatically. Doesn't matter for how long. But grades 1 and 2, you're not knocked out. But for grade 2, your confusion lasts more than 15 minutes. Grade 1, 15 minutes or less. You get dinged in the head, you're a bit woozy, but you shake it off and you're better in 5 minutes, more or less. You might still have a headache, but you're not confused or stumbling around. So obviously grade 2 is the biggest category. People who've been knocked in the head. Let's say a hockey player was not out on the ice, but is very woozy, needs help skating off, and they go into concussion protocol and they're held off from games for days, weeks, or even months. Like Sidney Crosby was about 6 or 8 months. They kept him off the ice until he started to pass all the tests coming back. He came back and has had a great career since then. So recovery is possible, but grade 2 is the biggest category. Now, other scales are actually a little more accepting of the mild label. So the World Health Organization, the Centers for Disease Control, and the American Academy of Rehabilitative Medicine, they all will allow you to be knocked out for up to 30 minutes and still be considered mild. I tend to disagree with that, or your Glasgow Coma Scale can drop from 15 to 13 or 14, which are sort of confused. Or post-traumatic amnesia can be up to 24 hours and still be considered mild. I think those are pretty wide acceptances, but that just shows you out there that some jurisdictions feel that the knocks in the head that do this are still considered mild. Now, whatever your definition is, there's some syndromes related to vision that are common. Sensitivity to light. In fact, people knocked in the head are oversensitive to all kinds of environmental stimuli, light, sound, too many sounds, too many conversations, movement of the world. So seeing cars go by or riding as a passenger in a car drives them crazy, gives them nausea. Migraine, whether they're a migraine person before and it's worse, or a new onset of migraines can occur after concussion, and sometimes they have a visual aura. And then less common, but does occur, is the inability to bring the eyes together to focus up close, to read or look at small objects. Getting back to photosensitivity, there's a reason why you see boxers after a match in the cool sunglasses. It's not just a fashion statement or because they have bruising around their eyes. It's because they're very sensitive to light after being punched a few times in the head. Migraine can cause visual auras, this sort of crescent-shaped scintillating scotoma that obscures the world behind it. Those of you with migraine know what I'm talking about. And there's an increased incidence of migraine with visual aura after some concussions. Then there's the whiplash itself. It's not all just about the neck muscles. The head is flung forward and back, and it's quite a stress on the neck at the mid-level of the neck, the cervical spine. As it turns out, if it's bad enough, you get shear injury of the neurons, the axons. If you stress them too much, they get damaged or even die. And this is a side view of the brainstem in the maximum area of flexibility of the neck. And if you put a line through there, you're getting into the third cranial nerve and what's called the Edgar-Westphal nucleus. Not to bore you with all the anatomy, but that's the nucleus that gives you the ability to converge your eyes, shrink your pupils, and accommodate to something up close. And that is possibly the reason why you have trouble focusing your eyes to read for a period of time after a concussion. Not often permanent, but sometimes it is. But it's often transient and goes away. You might need some help temporarily. So management of some of these issues, first of all, the overall concussion management, as you probably heard, is that less is more. You want to withdraw from environmental stimulus. You don't want to spend your brain capital on things that you don't really need. So first of all, you avoid sunlight, you adjust indoor light, maybe turn off fluorescence, incandescent light, indirect light is better. You wear darker tinted glasses as required. You limit the duration of vision-based activities on your screen or on your phone, take frequent breaks. And after a period of time, things settle, you can gradually increase your activity sphere little by little and challenge yourself. But usually challenge yourself with the things you would do in real life, not exercises that aren't necessarily worth it. Now, there's a lot of talk about lenses and a lot of marketing. The FL41 is a popular lens because it blocks blue and greenish light. It has the wavelengths that are blocked in the high 400s, low 500s. And why would they choose that? Well, it turns out that there is some benefit of those lenses in people with migraine. But to date, there's no evidence that that lens is superior after concussion. They did a trial with several different lenses blocking several different wavelengths and a plano lens, and asked people to try them on and take the one they picked. And they all sort of split evenly. So there was no patient-based preference for FL41. But because of its theoretical blocking of this frequency, it's marketed that way. To me, any lens, any tinted lens that makes the person comfortable is good enough for me. And I would use them freely, but not too freely. If you look at the bottom paragraph here, there is a study of 62 young adults with mild traumatic brain injury, and 40% of them had a delayed improvement in getting over light sensitivity, which begs the question, could wearing these lenses actually delay a recovery? You might need to challenge yourself a bit more. Obviously, there's a happy medium there somewhere. People shouldn't suffer with the bright light, but you don't want to become too dependent on it. You find your own pathway, really. Now, neurooptometry techniques, they've been around for several decades, but it was more popularized in the late 90s by this fellow, who is an optometrist in Connecticut, Dr. Padula, and he's given his name to his own institute and many different tests he does. So, and these are marketed online to optometrists who can take the training and set themselves up as neurooptometrists. Now, this has been going on for a while, and I've been asked eventually by many outfits, what about this optometry visual training? Is it any good? Is there evidence for it? I tried to avoid it for the longest time, but eventually there are these chat groups and the NANOS Neuro-Ophthalmology group, and everybody's asking the question. So eventually, one of my former colleagues who now is in Vancouver, Jason Barton, and I saw comments from each other and said, "Are you looking at that?" "Yeah, I'm looking at that too." So we decided to roll up our sleeves and actually deal with it. So we did a huge literature review of all of the optometry literature, everything we can get our hands on. It was so big that we submitted it to the Annals of Neurology, the top neurology journal. And they said it was too long, they couldn't accept it. So they either wanted to chop it words out, but we decided to snap it in half and publish half of it with them and the other half in a high-end ophthalmology journal, the Survey of Ophthalmology. So the topics are split between the two journals, and this was in late 2020. Both were published. And you heard in Leslie's introduction that I'm part of a panel that was developing guidelines, neuro-ophthalmology guidelines for vision therapy, and that's actually been done and published now. And a lot of the clinical work was based on the studies Jason and I did. So I might as well get the bad news first. There's a lot of flaws in the papers that they publish and quote each other on. First of all, the theory for some of the things they do is not really there. There's a key reference they always refer to that has the theory behind some of their practices, and they're probably hoping no one would find it. It's an obscure paper in 1972. Most libraries don't have it, but a good librarian at my institution found it, and I went through it, and it says nothing of the sort about closed head injury. It has a wide sort of survey of a bunch of different topics, including inner ear and light sensitivity and rats and animal models, but it doesn't really provide a basis for some of their activities or theories. The other problem is when they do studies, the subjects weren't blinded. Sorry. In other words, the subjects kind of knew they were getting the therapy as opposed to placebo. And even worse, the evaluators were not blinded. So the optometrists who were hoping for a result that would give them sort of work in the visual therapy area were the ones doing the evaluating, which is probably not really kosher in modern medicine. The sample sizes were very small. They're small, what we call open label. So small group of people, you gave them this therapy, you asked them how they're doing, you measured it, and that was it. There's no control group. In other words, there's no control group who were concussed in the head and given nothing and see how they progressed along with the other patients over time. They weren't controlled for the same severity of concussion or duration or age or additional conditions. Also, sometimes, what were they measuring? There's a couple of studies that they're quite proud of showing benefit, but the outcome was actually these visual evoked potential signals. I say, what? That's a signal of the measuring the length of time from vision hitting the retina to the back of the brain. It's not really a functional kind of measurement and nothing you would train your eyes to sort of deal with. It doesn't apply to real life. We usually use a test for MS patients because they get delayed signals. And of course, you don't have a control group, so there's no statistical analysis. It's just open label. We did it to these folks, asked them how they were. Some said they were better, some so-so. So this is the C.E.T.S group did a lot of the VEP studies. They were open label, no hiding the techniques, no controls. There were some of them were retrospective. They just looked up charts and looked back at what they were doing, computer-based review, and up to 8 months of therapy. And the thing I would criticize is that the visual evoked potential result, which they thought was a little bit different after training, is not really a credible way to measure visual function with the eyes or eye movements. And I thought to myself, why would you do these studies and put all that effort in and not actually mention an outcome for visual treatments like reading or reading endurance or comprehension? And they didn't mention that at all, which makes me suspicious that maybe it didn't do that much. It was a negative result for actual visual outcomes. And they just reported this other sort of electrical signal because it showed something. I don't know, but I thought it was odd. Now, the other thing is people have a lot of other symptoms after concussion, and many of you out there know that. So concentration is a problem. You get fatigued with vision, your comprehension is impaired. This really sort of contaminates the study and value of some of these studies and carrying them out. Now, they have developed this theory of post-trauma vision syndrome, which actually has no, as I say, biological basis. As I mentioned to you already, certain things we know happen after concussion to the eyes. You're more sensitive to light, sensitive to visual motion, that's a given. Now, whether those things could be trained away, no one knows yet. But also convergence and sufficiency may or may not be there, and may be something you can do, but it's never been proven for concussed adults. So there's no real evidence for this syndrome, which they expand on and give all kinds of other additional features. Then they have this thing called visual midline shift, a very elaborate description, a disconnect between the position of their perceived ego center and their true center of gravity. If anyone out there can understand that, let me know, because I can't. I'm not quite sure where the concept came from, but it turned out I found a paper that showed they were comparing it to people with stroke from a brain tumor or blocked blood vessel causing hemiplegia or hemiparesis. And of course, as you saw the huge damage on one side of the brain from large strokes, you will lose vision on that side, or at least lose awareness. And yes, you could have like a shift of your visual midline. But this is a CAT scan, a normal CAT scan of a person's brain. See the nice symmetrical gray, the ventricles are all symmetrical, the midline's there. This is what a concussed person's CAT scan usually looks like. It gets shaken up, it's not too bad, there's no bleeding, no skull fracture, it will look normal. You have to look more deeply to see the problems. Now, this is someone who's had a massive stroke on the left side of the brain. The entire middle cerebral territory is dark, and the swelling is pushing things over to the right side. Here's the normal side. Now, you can see the huge difference between those two anatomies. And yet, they're basing this midline shift syndrome on this massive stroke model. And that's really not at all what's going on in mild concussion, where the brain is shaken up back and forth a few times. And they use a test where they move a finger back and forth across the person's eyes and say, when it gets to the middle, say, okay, okay. Now, it's not a very technically adept test, if you can see. It depends on the speed that you're moving your finger, how aware and quick to respond the patient is. So if it's in the middle, they would say they're normal. But if it's over to one side, when they say yes, then they would say they're shifted to that side. So I'm not so sure about the reliability of that test. And then they then infer that the person's whole body is sort of shifted to one side. So one of the therapies is what they call yoked prism therapy, like yoking a cow in one direction. Most prisms are to realign the eyes. If one eye is higher than the other, you put a prism to lower it down and make it matched. Or if the eyes are too close together, you do a base out prism to move them apart. If they're too far apart, you do a base in prism to bring them together. But here, they're putting the prism in each eye pointing in the same direction to kind of shift the whole visual field in one direction. And as I said, the basis for it biologically is pretty unlikely, and the evidence that it actually works is pretty much zero. There's no well-done studies. Now, balance itself is very complicated. It comes from the inner ears through the brainstem, and only like strokes of the vestibular nucleus, like a Wallenberg syndrome stroke in the brainstem, or a stroke of the balance part of the brain, the cerebellum, can cause a kind of shifting of your visual world, and you make inaccurate saccades to one side or the other. Nothing like this happens, thank God, in people with mild TBI. And they don't even reference that in the neurooptometry literature. And again, taking an online course on postural stability based on midline shift, when there's no pretense to understanding the vestibular system, it's just not really serving the patient very well, in my opinion. Now, some of you may have seen or been prescribed binasal occlusion on your glasses, which is whether you wear glasses or not, you put a piece of tape on the inner part of each lens. Now, the width of it has been disputed, the density of it is disputed, or whether it should be tilted or kept straight. Now, what is this supposed to do? Well, it turns out this goes back to 1950 when a fellow called Louis Jacques prescribed it for strabismus patients. Once again, different thing entirely, mainly for esotropia. That's where they're born with their eyes too close together. You can kind of see the logic there, right? You have to look sort of outward to get past the patches, and that sort of subconsciously forces your eyes outward. It's a kind of training. Again, what does that have to do with a mild closed head injury where your brain's shaken up and you have sort of general symptoms? Nothing whatsoever. And then they have different ways of measuring reading. Instead of just reading out loud, they have a test called the DEM, which has uncertain sort of very basis, and it's supposed to be for kids anyways. And they test adults, and adults do badly on it. So they'll say, oh, she's reading an 11 or 12-year-old level with this test. And when I see them in my office, I have them read a couple of paragraphs from National Geographic, and they seem to be fine. One of the things they do will be saccade exercises. Saccades are the fast eye movements from point A to point B that you make. So keeping your head still, look to the one side or to the other. So they have people saccade back and forth to different points of light, or you put up a piece of paper with a clock put on the wall, and you look from the center to the 1 and back and to the 2 and back and 3 and back. It's kind of relentless and exhausting and visually tiring, and you'd better hope that it has a benefit to it. But it turns out there's no proven benefit whatsoever. And actually, saccades are a very complicated thing, and they're really hardwired in the brain. This is where saccadic signal comes from the front of the brain, goes down into some of the deep nuclei to make sure they're accurate. It's fed to the superior colliculus and eventually down into the brainstem to the eye muscles to move your eyes. And I don't want to get into detail, but it's a very complicated thing. And it's not, a little shakeup of the brain is probably not going to do it. It may affect your attention and concentration, but to actually damage the saccade construction and metrics would be in the brainstem, which we've shown before here, where saccades come from, would have to be smushed. And if that was the case, you'd be in a deep coma for weeks after your injury and probably be plegic and brain damaged for life. And again, we're not talking about that. We're talking about mild TBI. Now, my colleague Jason does a lot of work in the brain's control of gaze, and he said a more useful test would be to look at concentration on the task. So there's a thing called an anti-saccade. So if you're looking straight ahead and light flashes on the right, you're supposed to look to the left, and vice versa on the left. And think how kind of confusing that is. You really have to be on your game and pay attention to that, or you'll make a bunch of errors. So that would be a better test, but they don't do that. And it may be that tests of saccades, their accuracy and speed or response, might be a good test for how the cognition is doing in recovery, not due to the actual eye movement metrics themselves. As I say, it may be that these complicated, exhausting vision therapy testing methods are actually maybe picking up cerebral effects that masquerade as visual impairment. Concentration is down, you get visual fatigue, it can't last, comprehension's down. Any therapy that you give should prove itself against a placebo response or the passage of time. So this is a depiction of some drug, but I'm just using it as an example. So this is time 0. Let's say you're concussed here. This is time going forward. So the open circles have to do with placebo, no therapy at all. Why is it going up? Well, some people feel better on a placebo, but more to the point with head injury, everyone gets better over time to some degree and at some speed. Everybody's on their own path. So if you don't use anything, just holy water, you should get better. So 3 months, 6 months after the concussion, you should be better whether you've done therapy or not. But if you're going to do therapy, you have to show what's called a therapeutic gain. This would be the black squares here. This is how drugs get approved for market. They have to show an improvement that's measurable over a placebo. In the case of drugs, it would be a dummy pill. And they're blinded. They don't know what they're taking. And they get better scores time by time by time than the placebo does. And vision therapy should actually do that and have a placebo group and show a difference over the rising level of people who are doing nothing. Because of the passage of time, we all get better. You can't just give some therapy for 6 months and at the end of 6 months say, hey, how are you compared to the beginning? Oh, I'm better. We should be better anyways. It should be, the onus should be on practitioners to show that they're better compared to nothing. And that hasn't been done yet, unfortunately. That's the standard of modern medical science. So that's what Jason and I looked at. And we had another question too, is do the ocular motor signs that people have looked at, do they actually cause symptoms? Well, if it's convergence trying to read, yes, that your eyes are blurry up close, and maybe you need some help with lenses or strengthen your prescription. But it turns out that people with other brain things like problems with the cerebellum, which gives you impaired coordination, they don't actually have complaints like TBI, even though their eye movements are terrible. So it's not quite clear that the little changes in the eye movement mechanics that are reported actually cause symptoms. People have symptoms for a bunch of reasons after concussion. So as I say, mild TBI patients, when we examine them, I always find their eye movements are invariably normal. They have a lot of symptoms, but it's not due to problems with making eye movements. For the simple visually guided saccades, look here, okay? An anti-saccade, like I said, they might have trouble with, but that's more to do with higher upstairs, the concentration of the brain, not the actual physical mechanics of the eye movements. So as I say, it may be more value for testing comprehension and concentration. Now, the one credible form of vision therapy is for convergence insufficiency. The eyes can't converge. There's a trial called the Convergence Insufficiency Treatment Trial, C.I.T.T. And it did show, it was a well-done study back in 2008. They divided subjects into 4 blocks. One was like doing pencil push-ups, focusing on a pencil back and forth. The other was some home pencil push-ups with a bit of computer training. The third was a placebo, which is quite clever. They had them look at a distant wall and do certain things with their eyes. It's not up close, so it's not convergence, but the patients didn't know that. Very good design. And the fourth was in-office vision therapy with home reinforcement. And the study showed that in-office vision therapy was moderately better than these other methods. So great. Now the outcome measure was basically how are you feeling, symptom-based score, and then they didn't measure convergence. So good on them. There's only one problem. This study was on children between the ages of 9 and 7, children with crossed eyes, strabismus. They were born with convergence insufficiency. This is a treatment of primary convergence insufficiency in strabismic children, not adults with mild closed head injury after concussion. Okay, so it's really an apples and oranges thing. They took a childhood study for crossed eyes and have imported it into adults with mild TBI. And unless you do a study showing it works in the adult group, you can't really do that. So the National Eye Institute director at the time said the study was good. It will provide eye care professionals with the research they need to assist children with this condition, crossed eyes, not with concussion in adults. So it's really an apples and oranges comparison. So getting close to the end now, like what is missing from the optometry literature? So one of the things is that, primum non nocere, first do no harm. You don't want to do exercises and therapies to patients that are going to tire them out, worsen or delay their recovery from concussion, unless you have a darn good evidence that it's going to benefit them. So the way forward would be to think about the cognitive effects, maybe try different methods, now using video games. There's some papers out on this. And of course, better study designs, we can actually believe the results. So a well-done study has certain virtues. The size is big enough to get some stats. The assignment is random. You can't cherry pick who's going to go in group A or B. The blind subjects are blinded if possible, that they're getting a therapy. They don't know whether it's the real one or not. The evaluators must be blinded. So people carry out the testing, and then a different set of people will evaluate how they're doing visually and then make their score. There have to be definite diagnostic criteria in the different types of brain injury. Like we're talking, is it car accident whiplash? Is it bang your head? Is it trauma? In the States, blast injuries and war are becoming an increasing cause of it. You have to know your injury. And then you have to acknowledge, as I said, the natural improvement in mild TBI even without treatment. If you don't acknowledge that, you're kind of hoodwinking people. So we would recommend that new studies by optometrists do an untrained cohort matched for duration and severity of TBI, then reassess both groups after several months to make sure the treatment effect persists. It's not just temporary, and that the control group does not eventually catch up to the same level. So if you get to the same level at 6 months, why bother doing all the therapy? And you have to take into account what their cognitive function is. Are they compos mentis enough to understand the tasks? What medications are they on? A lot of them are sedative, and other conditions. Is there any underlying dementia or things like that? And outcome measures should be relevant to what they actually want to do, not some random measurement of a visual signal to the back of the brain. And of course, if you have a control group, you can do proper statistical analysis. Jason and I concluded one of our papers by saying, ultimately, advocates of vision therapy need to prove that the substantial time and money spent on oculomotor training by patients with limited resources actually achieves something and is not better directed resources elsewhere. You don't want to rob the system or the patient's health of energy and money that could be better spent on therapies that have some evidence basis. Now, there are some new exciting things coming out in the tech world. There's some new video game plays and other basically computer-based stimulation and training that's maybe better at getting the eyes back on track. We'll have to see what the results are there. But there's hope out there. But I think, again, vision therapy is offered by optometrists, and I'm not saying to do it or not. I think you just need to know what the evidence is for it or lack thereof, and be a fully informed consumer, and challenge them. So what we've tried to achieve today is look at the doctor confronts the pre-accident visual issues and subtract them out. There's a few rare severe injuries. Thank goodness we don't get them that often. In mild TBI, we look at what's common and known, sensitivity to light and motion, some migraines, maybe trouble focusing, manage those issues. We learn a bit about neurooptometry techniques and what you think of it. We did the critical review, and the way forward would be really the gauntlets thrown down for optometrists to maybe do some well-designed studies that reach 2023 levels of credibility in medical science. And then we can hang our hat on that. We'd be the first ones to want to review those and evaluate them and recommend them. So thanks for your attention. Hope I didn't go too long, and I'll be open to questions.
Great. Thank you so much, Dr. Ranalli, for an excellent talk. And we do have a few minutes for questions, and we've got some here. So the first one says, I have convergence insufficiency syndrome. Any tips for improving it? I was told to bring a pen towards my nose, and when it goes out of focus, try to force my eyes to try and refocus at that distance, but have difficulty figuring out how to do that.
Right. So that was using a pencil, a pen. So pen or pencil push-ups have been a time-honored sort of method of training your eyes. You're actually training your eyes to come together. And because it's hard to do, it's difficult to do. It's going to be tiring and blurry. So you start out low, start out with them far enough away, the pen that you can actually focus, and it looks pretty clear. Maybe have some writing on it that you can read. And then look in the distance, and then look back to the pen. Look in the distance, look back to the pen. And over the days and weeks, you can bring that a little bit closer until it's easier to do and less effortful. It doesn't cause so much headache or nausea. And that is a simple, pretty cost-effective, just the cost of a pencil. And that's the kind of training that neuro-optometrists do give to patients as well for home exercises, in addition to the other things they do. So I support it.
Great, thank you. From the same individual, I made an interesting discovery last week. I had seen a neuro-otologist, and he said when I'm walking, he wants me to rapidly turn my head side to side. When I do this without any glasses on, I get really dizzy. In fact, tried an experiment with my physiotherapist when I was walking with my cane and my distance prescription glasses and distance prescription sunglasses, and was able to walk quickly, turn my head rapidly, and turn quickly without symptoms of dizziness. But when we did it without glasses, I almost knocked someone over from turning side to side and had to sit down for 5 minutes before continuing my exercise. Can you explain how wearing my distance glasses is helping me with my balance?
Sure, and that's actually a good exercise, and that's not neuro-optometric eye movement training for concussion. That's vestibular training, so training to recover or enhance your balance system. Turning your eyes and being able to focus is a function of the vestibular system in the inner ears, which send that signal of head movement to the eyes to move them equal and opposite to your head movement, so the world doesn't look so jiggly. So that's good, but it's difficult to do. The reason why you want to wear, if you're prescribed glasses for distance, you want to wear them because the things you're looking at are, if they're more than 13 inches away, if they're like a few feet away, like TV distance across the room, then you want to have your eyeglass focused. No sense giving yourself another handicap. So wear your prescription glasses so you actually give yourself a break to focus. As I say, you have pre-existing visual need, the need to wear glasses. No sense taking that out and making it more difficult. And yeah, and if you're photosensitive after concussion, as most people are, and you are, wear your dark, so tinted, focused prescription glasses and do that exercise. So you've come to the start line with all your visual gear in place, and you're able to just try and work on your balance system. That's a very good exercise. It is difficult, and most of these things like pencil push-ups and that, they're hard to do and they're difficult. And if they wouldn't be doing anything. So the idea is to do it and get better at it and get better with time.
Great, thank you. Next question is, I was told to try the F41 lenses, but they're really expensive and I am super light sensitive anytime I'm in an environment with fluorescent light, especially. I guess any comment on?
Well, again, that's why I had to say that there's no good evidence that FL41 are superior, but they're marketed as superior, and so they charge the price for it. So they're probably lesser expensive tints that work just as well, or in general just as well. And I wouldn't spend a lot of money on it. And you can just try different lenses, and you be the judge. Whatever one you feel most comfortable with is good enough for me, because there's no science behind FL41 versus other tints.
Great, thank you. Jen asks, if someone wears prism glasses prior to concussion and you say light sensitivity may last longer if you wear prisms, do you still have to wear them after?
Actually, what I said was light sensitivity might last longer if you're wearing tinted glasses or filters like FL41 or sunglasses. That's what that study showed. Like, it gives you comfort and relief, but you have to gradually kind of go without them little by little so you don't delay your recovery. But yeah, if you had a prism before, you want to keep your same setup after concussion, no matter what you do. As I say, if you have pre-existing visual issues before, whether it's prescription glasses for distance or near or progressive bifocals, or some kind of prism for whatever reason, yes, for definitely keep that in place.
Okay, thank you. I tend to keep flipping numbers and letters and really struggling with how to correct this. I can't afford vision therapy. As a result, I'm really struggling to read anything.
That sounds terrible. And to me, that sounds like more of a cognitive problem. As I say, sometimes testing vision or trying to train vision brings out problems with the cognitive aspect of the brain, like flipping numbers and letters. That's not something, unless you're at really bad blurry vision, you're just guessing. That wouldn't be due to a pure visual issue. It's you're seeing it, but you're not registering it the right way. So that's more of a cognitive issue, and you may need to see someone who can work with that aspect of it. But the passage of time is a great healer for that as well. There's no actual like eye movement therapy that should improve that particular symptom. Like, why would it? you're actually misinterpreting letters. So almost like a dyslexic.
Yeah.
And dyslexia is a brain dysfunction that people are born with, and concussion can cause a temporary visual confusion, dyslexic-like. You're not focusing on it. So I think with time that will go. I wouldn't again exhaust my brain with alleged therapy to improve that, because I'm not aware of any.
Okay. Have you heard of the NeuroLens for concussion?
Yes, I've been hearing a lot about it, and we've discussed it in our specialty, and I'm not that big on it, because what it is actually is, I mentioned that they put some lenses in, like to shift the eyes one way or the other, and they usually put small sizes of thickness of lens, because if it did shift you and it was the wrong thing to do, you'd feel worse. So they don't want to do that. So you usually use a pretty mild lens. NeuroLens is that to the nth degree. NeuroLens is like homeopathy, really. It's such a slender little lens that no mortal person should notice anything. So it would be even less likely to have any therapeutic effect. So, and again, if it was free, you could try it, but I'm sure there's a fee for that. So it's not dangerous, but it's not much.
Okay. Yeah.
That's my take.
Okay. Erica is asking, can you speak more about double vision? I continue to have double vision 3 years post-concussion.
Wow. So that should definitely be evaluated by a specialist. Now, the first thing to do yourself is to make sure, is it binocular double vision? In other words, you're seeing something doubled. If you cover one eye, does it become single? Okay. Cover the other eye, does it become single? If you cover one eye and it's still double, that is not a brain or neural problem. That's a problem with the optics of the one eye. The light is getting split going in, whether it's due to a corneal problem or lens like early cataract or some damage to the retina. So, but that's what a specialist could do. I would see an optometrist first, and then probably have to see an ophthalmologist and or a neurologist or neuro-ophthalmologist. Yeah, that you definitely deserve an assessment there.
Okay, thank you. Years before my concussion, I fainted, and when an ambulance got me, I couldn't see for a short time afterwards. Could that have left some vision damage, even though I never had symptoms at that time? Now, 5 years post-concussion, I have daily headaches, mostly from screens.
Okay, so you had temporary blackout of vision, and we've all had this experience, just with a pre-faint feeling for whatever, like a blow in the head can cause things to go temporarily black. But more commonly, if you stand up too quickly and your blood pressure drops temporarily, maybe because you're dehydrated or you're sick with a fever, and you get up and your blood pressure drops, the world can sort of darken. And at that point, it's going to block and you're going to pass out. But if you recover, it goes away. So I'm not surprised at that initial loss of vision. That's quite typical of a blow to the head. Now, that's temporary by definition. It's not going to cause or have caused any permanent damage whatsoever. The symptom you're still having now is not a visual one. It's headache, and you have a post-concussive headache, and you're still sensitive to light, which is, it's unfortunate that you're that sensitive that long afterward. But I don't think it had much to do with the transient blackout at first. That just means you were knocked in the head. And I hope things get better for you. I would wear tinted lenses as required, but not too often.
Okay, great, thank you. I've heard about red light therapy and that some people do this at night to calm their system. Do you have any information on this?
Yeah, I'm not aware of any benefit from the light therapy. There are people offer these lights, and you stare at it for like 30 minutes or 20 minutes a day. And there's no credible published evidence showing benefit. So I'm not discouraging from doing it. If you notice an improvement, go for it, but there's no evidence of it. One of the weird things is their literature has recommendations for FL41 to block blue light as a treatment, but other practitioners recommend blue light treatment. Stare at a blue light for an hour every day. So which is it? Do you need more of it or less of it? So this just points out there's not a lot of hard science behind it. And if anecdotally, if you hear of something or you want to try it, by all means, but don't get led astray that there's really good scientific evidence, because there isn't. We reviewed prisms and light therapy in our papers as well.
Okay, great. Lynn is asking, can you explain some of the vision symptoms people seem to report a lot post concussion? So strange lights in the visual field, objects moving, and so forth.
Yeah, well, a knock on the head can cause anything like that. I would say strange lights in the visual field sounds like a migrainous visual experience. You can get migraine visual auras without the headache. We see that in regular migraine folks. Weirdly, you might have migraine with headache when you're younger, but as you cross sort of middle age, mercifully, the severity of migraine headaches tends to diminish on its own, but the flashing lights can still occur for 10 or 15 minutes. Just like the original migraine. It's not painful, but it's so, but if they are persistent, you do need to be investigated. You need to see a neurologist and maybe get an MRI scan. You want to make sure there's nothing, just because you get knocked in the head doesn't mean you can't have something inside the brain that's like tickling the visual area. That's a common faux pas for neurologists to make assumptions that it's due to this when it could be something new. None of us are immunized from other diseases, so.
For sure. Thank you. Is there a connection between severe dry eye and concussions?
There isn't a connection, except that severe dry eye is very common. And it's usually an age-related thing as we get older. I have a lot of it. You just can't squeeze out those tears like you used to. And then other things can aggravate it. So wearing contact lenses makes your eyes dry. Working outside makes them dry. Being anxious, because your eyes are more open a lot of the times, they become dry. So it's just a very common cofactor in visual symptoms. So if your eyes feel tired or sore or a little bit gritty when you blink, that sounds like dry eye. You don't need a fancy doctor to diagnose it. Just go to the shelf in the pharmacy. There's about a dozen different types. They're all good. And treat yourself to that. And you be the judge. Put them in 2 or 3 times a day. Does it make you feel better or not? A dry eye can aggravate all of these visual symptoms: eye pain, headache, eye fatigue. So you might as well treat that one. It's an easy one.
Great, thank you. Okay, I'm just keeping an eye on the time. Let's do a couple more. So Marisa says, I had a concussion from playing hockey 6 years ago and still have many issues with movement around me. I have a hard time with busy environments, driving, and so forth. Are there any practices that can be implemented that can improve sensitivity?
That's a shame, Marissa, because that's a common early post-concussive syndrome. So again, I don't know if you were held off the ice for a while, but if you had symptoms like headache and dizziness and that, you would, hold an athlete off and just total rest. And then the first stage would be just to walk around, you get symptoms, and you go back and rest in darkness. Then you start to do fitness, and you work out in the gym, maybe cycle. If that brings in headache and visual motion, you step back again, and gradually, little by little, 2 steps forward, 1 step back, get on the ice and skate, but without playing hockey, without contact. And I had a hockey player, a major junior A, and he was fine till he got on the ice, and then just seeing all the seats go by really made him dizzy. But that was early, that was within months. For you to have it 6 years later is really unfortunate. I think the kind of vestibular therapy that was mentioned earlier involves different things like walking and turning your head side to side, sort of window shopping sort of exercise. That might help. And other things where you move your head and try and focus. Again, it would make you nauseated and dizzy to do it, but it might harden you for ordinary activities and make the dizzy feeling of motion settle down over time. The other thing is we can wear tinted glasses indefinitely, because think of it, it's not just for light sensitivity, it's also for motion sensitivity. So if you're bothered by the movement of things around you and they're bright overhead fluorescent lights like at Walmart and high contrast, it's going to be worse. But if you dull it down, it's sort of more murkier, it's going to be the same movement stimulus is going to be less strong. So you can use those.
Thank you. Dr. Tatter has a question for you. What can help with using a computer after a concussion?
Sorry, Charles, what was the?
So what can help with using a computer after a concussion? So I guess if someone is having difficulty with screens and light intolerance.
Right. Well, of course, Charles is too modest to say he's carrying out a study on the effect of computer-based lighting and flickering in concussion. But aside from that, some of these computer-based programs, if you can tolerate them, have to do with doing certain visual exercises to learn to recognize things in different visual fields. None of this has come out with good evidence yet, but it's part of the training that's probably part of the modern way. And we'll have to see. Game developers and computer stimulus developers are working on this in a therapeutic way, and we're hopeful there'll be some benefits there. But it's a little too disorganized yet, Charles.
Great, thank you. Okay, we're over time. I'm going to ask one last question. I think it may be quick. It's how soon should we encourage people to stop wearing sunglasses? So people will often wear sunglasses immediately after their concussion.
Sure. Well, a lot depends on the severity of the original injury, but based on that, I would think is after a couple of weeks, I really want to start talking them into either having a pair that's less dark or taking their glasses off more frequently in darkish environments and then gradually. So I would think in general, even with mild concussion, moderate concussion, 2 to 3 weeks. It's not too early then. If they can tolerate it, and if they can't, they take a step back to where they were and then move forward again. But you don't want to curl into a fetal position and ignore the world, because you might end up staying there.
Yeah, exactly. Well, Dr. Ranalli, thank you so much. We've gone a little bit over time, but really appreciate you coming back to present and to answer all the questions. Apologies that we couldn't get all of the questions addressed, but we got through a fair number. So thanks again. And for those of you watching, you'll know that you'll get be receiving a short survey. So we always really appreciate if you can take a minute or two to complete that. And if you have any suggestions for us, please do let us know. And we will be back again in 2 weeks. We have Eden Dales with us, who's going to be presenting when and why to consult a social worker. So thanks so
Thanks for your
much.
attention, everybody. And thank you, Leslie and Charles.